There's a pattern that confuses many patients. Their A1C improves. Their doctor is encouraged. The lab report shows progress. But their neuropathy feels worse. Burning increases. Numbness spreads. Balance becomes less reliable. And the natural reaction is, if my sugar is better, why are my nerves worse? Now, that's a fair question, and it deserves a precise answer. Because the assumption underneath it is logical. High blood sugar damages nerves, so lowering blood sugar should protect them. Sometimes it does, but not always. And the reason is structural. A1C measures exposure. Neuropathy reflects system behavior over time. Those are not identical domains. A1C reflects the percentage of hemoglobin molecules in red blood cells that have glucose attached to them. It estimates average glucose exposure over roughly 3 months. It's useful. It predicts long-term complication. It correlates with macrovascular outcomes over years. But it is an average, and averages conceal dynamics. 2 people can have the same A1C. One may have relatively stable glucose all day. The other may swing dramatically between highs and lows. The number is the same. The cellular environment is not. Nerve tissue does not experience averages. It experiences moment-to-moment conditions, spikes, drops, oscillation, inflammatory shifts, perfusion variability. Averages smooth that out. Biology does not. Chronic hyperglycemia causes damage. That is established. But neuropathy is not governed by exposure alone. It is governed by cumulative instability. Instability includes glucose variability, hyperinsulinemia, endothelial dysfunction, mitochondrial stress, inflammatory tone. Lowering A1C reduces exposure. It does not automatically restore stability. That distinction explains much of that paradox. Neuropathy develops over years. Microvascular strain accumulates gradually. Mitochondrial stress accumulates. Inflammatory signaling accumulates. Axonal injury accumulates. So improving A1C over 6 months does not reverse 10 years of biological strain. Lab values can improve quickly. Tissue repair cannot. Axonal regeneration occurs very slowly. Schwann cell remodeling requires sustained stability. Microvascular architecture adapts gradually. Repair operates on a different clock. So, when A1C improves and symptoms persist, that is not contradiction. It is time-scale mismatch. The lab reflects recent exposure. The nerve reflects cumulative history. Early neuropathy is often functional. Energy production becomes inconsistent. Ion channel behavior destabilizes, and symptoms fluctuate. Later neuropathy becomes structural. Axonal density decreases. Fiber loss occurs. At that stage, lowering glucose exposure prevents further damage. It does not guarantee regeneration. If structural loss has progressed beyond a threshold, improvement may be limited. A1C improvement prevents additional injury. It does not erase prior damage. That is biology. Insulin resistance often precedes diabetes by years. During that time, insulin levels rise to maintain normal glucose. A1C on your labs may appear normal or even acceptable, but hyperinsulinemia can impair endothelial signaling. It can increase sympathetic tone. It can maintain inflammatory activation. So A1C can improve while underlying signaling strain persists. Lower glucose, persistent instability. Different layers of the same system. There is another layer. Rapid glucose correction can temporarily worsen neuropathy symptoms. This has been documented in literature as treatment-induced neuropathy. When chronic hyperglycemia is corrected aggressively, osmotic balance shifts, ion gradients adjust, microvascular tone changes, and inflammatory signal recalibrates. Highly sensitized nerve tissue may react. Symptoms intensify temporarily. This does not mean control was wrong. It means nerves respond to abrupt environmental change. Nerve tissue prefers gradual adaptation. Stability is therapeutic. Shock is destabilizing. Some medications lower A1C by increasing insulin production or enhancing insulin activity. Glucose decreases, exposure decreases, but hyperinsulinemia may persist. Endothelial dysfunction may persist. Mitochondrial inefficiency may persist. This is not a critique of medication, it's a clarification of mechanism. Glycemic control and metabolic restoration are overlapping but distinct. Lowering glucose does not automatically normalize nitric oxide production. It does not automatically resolve oxidative stress. It does not automatically restore microvascular reliability. Nerve health depends on capillary level perfusion. Insulin resistance impairs nitric oxide signaling. Capillary dilation becomes inconsistent. Even when glucose improves, endothelial remodeling takes time. Endothelial cells require sustained metabolic stability to restore function. Months of improved A1C may not yet reflect fully restored microcirculation. Without consistent perfusion, repair remains constrained. Even under ideal conditions, nerve regeneration is slow. Axonal growth occurs millimeters per day at best. Myelination must be restored. Schwann cell function must normalize. Mitochondrial density must increase, and inflammatory signaling must decrease. These processes require sustained environmental stability. Short-term improvement in labs does not immediately translate to structural repair. Expecting immediate symptom reversal from lab improvement ignores biological pacing. So let's look at two clinical scenarios. First one, a 64-year-old patient lowers A1C from 8.3 to 6.9. They improve diet, they lose weight, but burning pain increases at night. Now, why could this be? Persistent glucose variability despite improved averages, ongoing endothelial dysfunction, structural small fiber loss continuing from prior years, rapid metabolic shifts increasing temporary sensitivity. None of these contradict improved A1C, they reveal complexity. Another scenario is a lean patient with an A1C of 5.8 presents with neuropathy symptoms. Fasting insulin is elevated, triglycerides are rising, HDL is low. This reflects insulin resistance without overt hyperglycemia. A1C alone does not capture signaling inefficiency. Neuropathy may progress despite normal numbers. Again, exposure is not the entire story. Modern medicine favors single metrics. They are measurable, they are standardizable, they are convenient. But neuropathy is multifactorial: metabolic, vascular, inflammatory, mechanical, neural signaling. Reducing one metric does not automatically restore system integrity. Systems recover when multiple constraints are addressed. Progress is not merely lower A1C. Progress includes reduced glucose variability, improved insulin sensitivity, improved endothelial function, lower inflammatory tone, improved sleep, increased muscle mass, reduce visceral fat, improved autonomic balance. Multiple factors. When these improve, stability improves. Stability reduces cellular stress. Reduced stress supports repair. Now, lowering A1C is beneficial. Chronic hyperglycemia is damaging. That remains true. But A1C is not a complete proxy for nerve recovery. Neuropathy progression reflects cumulative instability over time. Improved labs are necessary. They are not sufficient. A1C measures exposure. Neuropathy reflects cumulative stress and system behavior. Exposure reduction is a starting point. Stability restoration is the goal. When someone asks, if my sugar is better, why are my nerves worse? The answer is because averages improved, but structural recovery requires time. Because exposure decreased, but signaling instability may still be present. Because damage accumulated over years, and repair requires sustained stability. That's not contradiction. It is layered physiology. Neuropathy is not governed by a single lab number. It is governed by the interaction between metabolic stability, vascular integrity, inflammatory load, and time. A1C can improve while neuropathy worsens because exposure reduction does not instantly reverse cumulative stress, restore microvascular function, or rebuild damaged fibers. Progress requires sustained stability across multiple domains. When that stability is maintained long enough, trajectories shift. Gradually, predictably, intelligently. That is the difference between chasing numbers and rebuilding systems. And systems determine outcomes.